Thank you, George. And welcome, everyone. These are my disclosures. None of these are really that pertinent to this. But as you know, multivessel disease is a problem in acute MI. It occurs in 40 to 65% of the patients. In general, it confers a higher risk of mortality and morbidity. We know that PCI of the infarct-related artery is beneficial. However, the benefits of treating these non-culprit vessels are really unknown. And there's a lot of reasons why we should not perform multivessel PCI. First of all, every time you dilate a lesion, it definitely increases the risk. These non-culprit lesions, the severity of these lesions is often exaggerated due to vasoconstriction during the acute MI. We know that there's enhanced thrombotic inflammatory states, which could make the vessel thrombose. Adding additional PCIs make the case longer, more complex, additional contrast, which can cause nephropathy and result in hemodynamic instability as well. In addition, this additional time, cost, more radiation exposure to the patient and to the operator. But importantly, these benefits are really not proven. And there's been several studies showing this exaggeration of the non-culprit stenosis, but here's just one I wanted to show you where they had 112 patients with multivessel disease, and they performed follow-up angiography about within the first 9 months of the acute MI, and imaged this non-culprit lesions in matching views. And what they found is both the MLD as well as the percent stenosis had pretty substantial, highly significant improvements despite being left alone. In 21% of these patients with a so-called significant non-culprit lesion at the time of the acute MI were then found to have insignificant lesions following this follow-up angiography. So had we treated all these, we would have been inappropriately treating 21%. Here's another study looking at similarly 121 STEMI patients with multivessel disease, and some of these were randomized to early FFR guided, some were randomized to conservative care. And at the time of follow-up catheterization, when they wanted to do the FFR guided PCI, they found that the FFR was in fact not significant in 40% of lesions. So this study suggests that were we to treat all these lesions during the acute MI 40% of the time, we would be doing the wrong thing. Now, there's a few very small randomized trials. One of these randomized trials enrolled only 69 patients, and what they found is that if you were randomized to multivessel PCI, of course you gave more stents, you used more contrast, and the procedure duration was longer. And although they found that multivessel PCI was safe, there did not appear to be any clinical or economic advantages to this. Now, what do some of our registries show? Well, we, of course, everybody participates in the NCDR, and they actually had about 31,000 patients with multivessel PCI undergoing multivessel coronary disease that underwent PCI within 7 days of acute MI. And what they found is that if they had single vessel PCI, shown here in yellow, they had lower risk of mortality compared to those patients who had multivessel PCI. And it didn't matter whether the patient just had STEMI alone without cardiogenic shock or STEMI with cardiogenic shock. Even with cardiogenic shock, an area where our guideline says it's acceptable, you see the mortality was significantly higher if you did a multivessel PCI compared to a single vessel PCI. Now, of course, sometimes these multivessel PCIs are occurring in sicker patients, and in this particular study, they found that multivessel was more likely in delayed presentations, heart failure, shock, anterior MIs. And importantly, if you're in a high-volume, non-teaching hospital, I guess we think we know what we're doing more, and we just are more likely to do multivessel PCI during the acute MI. But if you look at these adjusted risk, if you look at these patients with cardiogenic shock, even adjusted for all these differences and comorbidities, they found that there is a significant increased risk of mortality with the multivessel PCI being done in cardiogenic shock, as well as you see the adjusted ones in the STEMI patients without cardiogenic shock. So basically, regardless of whether they have shock or not, I would not recommend doing a multivessel PCI. And here in New York, you looked at this situation with STEMI patients and multivessel disease, and they were propensity matched to patients who had infarct-related artery PCI only. And you see there are a lot of differences here, and the bottom line is that the in-hospital mortality was significantly higher, and it also trended to be higher at 24 and 42 months in patients who had multi-vessel revascularization at the time of PCI. And then if you look at this particular meta-analysis, which took into account all of the randomized trials at the time, of course this PRAMI trial is not in it yet, as well as several of the observational retrospective trials, what they found is that the culprit vessel only appeared to be beneficial. And if you look at the mortality rate of pooling all this, this favors culprit only PCI as opposed to multi-vessel PCI. So, and also there's some additional studies I'm going to show you. If you really feel the need to do a multi-vessel revascularization, I would plead you don't do it during the acute MI intervention. Just go ahead and stage it at a later time because it does appear to be safer. Now, these are some, again, a small study. Politi, who randomized 200 patients, and what he found is if you did the culprit only, they did tend to do worse, but the staged intervention did appear to be the best way to approach these rather than the acute multi-vessel. Similarly, in the Horizons trial, they had 668 patients who underwent multi-vessel PCI. Some of these were during the primary PCI, and some of them were staged. They found that mortality rate was much lower in the staged group compared to the patients who had that done during the acute intervention. Now, keep in mind that Horizons excluded patients with cardiogenic shock, and so there should have been no hemodynamic reason to do the multi-vessel PCI. And so these patients should have been pretty well matched. And so not only was there an increase in mortality, but there was also an increase in the risk of stent thrombosis as well as an increased risk of bleeding by doing a multi-vessel PCI during the acute MI intervention. Another meta-analysis looking specifically at this immediate multi-vessel PCI versus waiting a few days for a staged PCI. Again, this one favored staged PCI. So the bottom line is pretty much every thing you look at favors not doing it or at least staging your multi-vessel intervention until PRAMI comes along. Now, PRAMI, of course, is preventive PCI of the non-culprit lesions. They only randomized 465 patients with multi-vessel disease after primary PCI to receive either complete revascularization during the acute setting, culprit only, and it is suggesting that there is improved survival, improved outcomes in this group. But there are a number of criticisms. First of all, it's only a small sample size, and I don't think any of you in the audience would believe that a 465 patient trial is enough to prove that there's any differences in clinical outcome, let alone differences in mortality and reinfarction, etc. And it took them 5 whole years to enroll only 465 patients. So I think there's been a lot of changes in how we manage acute MIs during those times. Also, the study was stopped prematurely because they cannot enroll. The reported benefits observed in these trials are really too extreme to be real and to be believable, and I think it's probably related to chance. The non-infarct vessels that were treated did not undergo FFR or even QCA, the quantitative coronary angiography, and so we're really uncertain about how significant those lesions are. EF is not reported, and it really has limited applicability to the United States because here in the U.S. we do not ignore tight lesions. We either perform a stress test or we would schedule them for a staged PCI, and that was not addressed here in the PRAMI study. The bottom line is that a lot of people agree that there's not enough data. There's tons of other studies going on right now looking specifically at this issue about should we treat these patients immediately or should we stage them or should we treat them conservatively. So in conclusion, I think there is a lot of information suggesting we do not perform multi-vessel PCI. The non-culprit lesion is often exaggerated during acute MI. There's enhanced thrombotic inflammatory states that can make multi-vessel PCI dangerous. It creates a longer, more complex procedure with more contrast nephropathy, more hemodynamic instability, more time, more radiation exposure, and more cost. And finally, the benefits are not proven. In fact, many studies suggest it may be harmful. So I think we should continue following the guidelines that PCI should not be performed in a non-infarct vessel. Thank you very much.